Okay, good morning and welcome back to the fourth Asian Perspective in Liver Disease OIPLD 2016. Today, the first session will be Hepatitis B guidelines over the decades, which is a part of APLD and Italian Joint Symposium, focusing on the Asian and Mediterranean perspectives in the management of hepatitis B infection. I would like to introduce my first speaker, Professor Satawat Thongsavat from Chiang Mai University. Professor Satawat is a well-known hepatologist with long-term experience in research and clinical practice, and is currently the head of the GI Division, Faculty of Medicine, Chiang Mai University. He is also the immediate past president of the Thai Association for the Study of Liver Disease, or TASO. He will talk about the Asian Perspective Guideline of hepatitis B. Please welcome Professor Satawat.
Professor Chair, ladies and gentlemen, thank you for your kind introduction and good morning everyone. My task is to show the perspective from an Asian on the guideline development over the decades. In Asia Pacific, we have quite very high diversity. Asian Pacific area comprises of more than 50 countries with so much different in terms of economy. We have a very mature developed country like Japan, and we have a very poor country like Bangladesh or Cambodia. We have a large country with more than 1 billion population like China or India, and we have a rather small country like Cambodia or Singapore with under 10 million population. And in Asia, we have different race and culture, different kind of politics. Just like in Thailand, now we are under the coup d'etat military regime, but people seems to be happier than under democracy system. And in Asia, we have quite quick paces of change, just like China. China changed a lot in the past 20 or 30 years. So first thing, I would like you to bear in mind that we have a high diverse area, and to develop the guideline for Asian Pacific area. I'm not in the committee, but several sit here like Professor Thira or Professor Anuchit. The committee, I think that know this very well and try to develop the guideline that can accommodate the whole area of the Asia Pacific. So this is the picture of the from WHO of the total expenditure on health. You can see that among the colors, there are several tiers of expenditure. Thailand here, we are among the not so bad expenditure, partly because of the universal coverage. So we are somewhat the same as China, or even better than India. It is quite entertaining to go back and read the guideline from the first one to the current one. In 15 years, there are 6 guidelines developed, and each has its own perspective. And as I said, other than the scientific aspect, the committee who developed the guideline over these 15 years has their perspective on other aspects of the Asian countries as well. This is the first guideline in 2000. The guideline was developed for both hepatitis B and C. At that time, when I go back and read it, it's kind of funny because the treatment is ALT based. If ALT is abnormal, you should treat. And at that time, we have only the alpha interferon, the conventional one, and lamivudine available. So the guideline is quite short, and the coverage is not so much. Then, 2 and 3 years after that, we have the new drugs, the adefovir as a rescue drug, and the emerging of entecavir. So the guideline was updated. And at that time, there was the ASD and EASA guidelines. So in the guideline of 2003, there were many changes. And the point of interest is that in the guideline, there is a list of several unsolved issues. And the third updated was done in 2005. At that time, there was the coming of, again, the new drugs, PEG, interferon, and terbividine. So new drugs are incorporated into the guideline. And at that time, there comes the role of the viral load test, which developed from the hybridization into the true viral load test, developed by Roche. So in this guideline, the point is that to treat and monitor the treatment with the viral load. And there are some addition about the consideration in special groups, like in the pregnant women, in the transplant patients. And the fourth, now, Apasser has its own journal. This one is published in Apasser's own journal, the Hepatology International. And this one comes out because of the roadmap concept. And I think that the roadmap concept is somewhat proper for Asian countries. In Europe or in the US, at that time, although the roadmap concept was developed in the US, but I think most of the US specialists, they don't believe in the roadmap concept. They're going to use the best drug that they have. But in Asia Pacific area, we still use this roadmap concept, and I think that we use it until now, and maybe in the next few years in the future as well. And in this guideline, the committee developed the algorithm for the simplicity of starting the treatment and monitoring. And the fifth one in 2012, because of the new technologies like the elastography or the fiber scan, the ability to measure the or quantification of the HBs antigen, and the result and report of the review study, and the coming of the new drug tenofovir available in Asia Pacific area, there comes another big update. And in this guideline, I think that the committee follow the ASD guideline. They show many commonly used terms with more refined and the explanation in detail. Although the roadmap concept is still there, the committee have something to say about the available and the preferred drug. I think that this is because, again, due to the diversity of Asian countries, the rich country, I think, can omit the roadmap and use the preferred drug. But the poor country, we still need the roadmap concept to guide the use of HPV treatment in our country. And the current one issued last year, this one I think is a very long guideline, 89 pages. And other than the things in 2012, the added issue is the grade system, so that the reader can make the decision according to the grade of recommendation. Again, I would like to show my perspective that in Asia, we need to think about the economic concern and the different healthcare system. I'm not quite sure about the healthcare system in other countries, but in Thailand we use what is called the universal coverage. It means that the government will pay or reimburse everything that the patient needs. This costs the government a large amount of money, and if there's no reform, the country will go to bankruptcy soon, I think. But anyway, because this is a universal coverage, the government says that for treatment of hepatitis B, we need to start with LAM only and then switch to tenofovir if there is any resistance. There is nothing said about the use of peginterferon and nothing said about other drugs. There might be some change this year or next year because now generic entecavir is available. So there might be some change, but nothing is announced yet. The other choices like peginterferon or terbinafine and entecavir now is under self-paid or under other reimbursement system, like the government officers whom the government will pay for the reimbursement. In the next futures, I think that at least in the 5 years, as we know, there wouldn't be any new treatment emerging. New drugs are under development, mostly in phase 1 or phase 2. So the treatment scheme wouldn't be changed. The roadmap, I think, will stay there. So in the next 5 years, if there is a new guideline for Asian Pacific area under PASO, I still think that roadmap is going to be commended there, not omitted. So it's going to be in use, and I think that is a good strategy to use in many countries. And the use of the preferred drug like entecavir or tenofovir as a first-line treatment depends on the financial concerns. As I said, in Thailand, it might be possible if we can have the generic drug in a rich country like Japan, Singapore. That shouldn't be any problem. It can be used. So in summary, I think that in Asia Pacific area, each country with different income and healthcare system will use a partial guideline as the guide to develop their own proper guideline for their countries. And I think that is the perspective of mine on the Asian guideline over the decades. Thank you.
Thank you very much for your excellent talk. May I present the second speaker? Our next speaker is my co-chairman, Professor Florencio Bonini from University of Pisa. Professor Bonini is a world-famous hepatologist. He is now the president of the Italian Foundation for Research in Hepatology of FI. He has published more than 200 articles about hepatitis B, C, D, and liver cancer, which has been cited for more than 10,000 times. He will get lecture on the Western perspective of hepatitis B guidelines. Please welcome Professor Bonino.
Thank you very much, Professor Pisit. Thanks, Ivanic. I will just discuss a few points which are related to the changing guidelines over time and the perspectives for the near future after the presentation of Tong Sawat, where I found that most of the similarities are present in the management of this disease in the different parts of the world, and some differences are related particularly on the economic constraint. In terms Let's see if... Is this to go? Maybe go with this? Okay. What happened in the last 10 years is that we actually didn't introduce new major achievement at the clinical level. Therefore, as we already seen in the last 5 years, no major changes in the PEG interferon and nucleotide analog remain the only drugs in the treatment. So the guidelines now are trying to dwell on tailoring antiviral treatment at the single patient level, and this may be a realistic target. So at this point, most of the guidelines start to put one most important issue of evidence-based medicine, that is, ask the right question. This is the real point, because if we don't ask the right question, we have a series of problems coming back, and this reminds the old Oscar Wilde aphorism that anybody is able to answer a question, but the real point is to have the right question, and only a genius or an expert can pose the right question. And this comes back to the triangle of evidence-based medicine that started from the founder of the evidence-based medicine, that we have actually a little bit forgotten, because as you see, one of the major part of the triangle is clinical expertise and expert opinion, and is not flipping the coin statistics. Instead, nowadays we have forgotten that, and guidelines are much stuck to the current medicine, that is McDonald medicine. McDonald medicine is important to avoid diarrhea and avoid problem, but there is a cuisine that is up McDonald. And this evidence-based part has been dismissed and faded by the current opinion leader. So definition of evidence-based practice started to be changed after Sackett, and some of the important issue, that is conscientious, explicit, judicious use, and the care of the individual has been missed already after a few years in a systematic search, flipping the coin concept, and what was a must became a might. So already at the beginning, there has been a derived switch from what was the real aim of the evidence-based medicine, particularly in evidence-based practice. Why I am dwelling on this? Because when we switch from evidence, that is clinical trial, where we have all individuals that have to be considered artificially identical, we move to clinical practice, then we have an individual differential condition, and we need to identify the treatment of the real patient, which is completely different from any other. And so the clinical epidemiology is useful to identify and decide whether a determined diagnostics or therapeutics goes to the market. But once we have the instrument in the market, the decision which one in the cassettes of instruments should be used for that person is a completely different step that is actually completely missed. And guidelines today are designed on evidence, on clinical trials, not on the second. We do not do cohort studies, so we are missing, completely blind. And we cannot take a decision in the single patient with the logic of the blind that is guiding the blinds. This is a tremendous, dramatic word for the young earth. So let's change and try to think. Let's pose an important question of the guidelines all over that is being dwelled in the last 5 years. Is the differentiation of active chronic hepatitis B in the E-negative carrier versus asymptomatic inactive, real inactive carrier. This is one major question. And this is actually the story reported in the recent guideline of American Association of Study of the Liver, where they, for instance, point out that the dynamic of chronic infection in the E-negative phase make a difficult point to distinguish these two conditions, chronic hepatitis B negative versus asymptomatic carrier, and they dwell on the meaning of monitoring viral and transaminases, since there is a problem of fluctuation, and this is actually what they pointed out. But a major logic problem is that the consideration of transaminases as a specific marker of hepatitis B disease is a completely wrong idea. Transaminases is a marker of unspecific liver damage. And anytime you have a person in front of you, you cannot tell that transaminases elevation is related to the virus, even if there is an infection. You need to demonstrate that. In any patient with HBV infection, elevation of ALT does not mean that the virus is making the damage. This is a very big mistake that we have not to consider. So the relations has to be analyzed, because we may have other cofactors, steatosis, other conditions are now frequently associated with chronic hepatitis B virus infection. Already many years ago, how we could dwell on this issue. This was our problem already in 1993. And the conclusion were at that review that quantitative and dynamic analysis of hepatitis markers could be the most suitable and reliable method for monitoring. So we posed the right question in evidence-based condition, and then we studied that. And the step had to distinguish active from inactive since the 70s to 2010. We made a lot of steps. It will be a long time to discuss them, but let's come to the last point, and I will not detail on this issue because other speakers will talk about that during this day. So at this point, in the last 10 years, a lot has been done monitoring quantitatively hepatitis B virus markers, and this has added a consistent step ahead for management in clinical practice. Nowadays, it's possible to identify the active carrier using a series of markers, not only transaminases and HBV DNA, but HBsAg and total anti-core quantitation can help to do that, and to understand whether this person who is asymptomatic is really an active carrier with chronic hepatitis B or an inactive carrier. The other issue is, in this natural history, the inactive carrier phase versus reactivation are pattern of the same category of individuals, or are we talking about different categories already from the beginning? Because actually, what we see in clinical practice very infrequently, the inactive carrier, the real inactive carrier, to become chronic active hepatitis. I am always talking about the negative phase. So it might be that the old classification in different phases, in particular in the immunoclearance phase, chronic hepatitis B, either E positive and E negative as one category, and the inactive carrier, where there is the immune control of the host, as another category, could be still a condition that holds true in the real life. And just to talk about that, we have to remember that chronic hepatitis B E negative is characterizing, in about 50% of cases, of a condition of remittent reactivation phase intervening with completely normal transaminases, very low viral load phases, mimicking the asymptomatic inactive carrier case. So, keeping in mind this, we have to monitor consistently and frequently the patient or the individual in this phase to be sure that we make the right decision. And I just referred to a recent work that Maurizio Brunetto has submitted for publication in a long series of cases studied over follow-up that stem from a few years, a few months, 8.5 to 158. So a long follow-up in individual who have been well studied and characterized at the beginning with monthly monitoring of viral load and transaminases. And it happens, to make a long history short, that very few of those who have mild elevation of viremia over 2,000 international unit, which are defined as low viremic active carrier, just one only had actually reactivation after the definition of a very stringent criteria during the first year. So that means that there is actually a completely different condition already from the beginning. So rather than reactivations, we have to be careful to define inactive carriers from the beginning, and these individuals who actually look like active low viremic probably are the first stage to inactive carrier condition. And the direction of the outcome is 99% in this one, not the other one. So it means that already the condition is versus immunocontrol of the virus. Then maybe in the future the guideline could be considering also the issue of the immunologists which are not happy with the definition of immunotolerance, because there is a strong activation of the immune system even in those who have high viral load and the antigen positive carriership, and better maybe call it non-inflammatory active phase, then inflammatory active phase, then immune control. So simplify, but more logically linked with what is actually the evidence base in practice. And in the immune control phase, we have different stages, initial, minimal, then more important, and then, of course, more consistent control. If we dwell on some of the most important questions, for instance, very well pointed out by the guidelines of the ACLD, should adults with immunoactive chronic hepatitis B be treated? Everyone with antiviral therapy to decrease all the complications? Should adults with immunotolerant or the non-inflammatory active phase be treated? These are the most important questions. And then the members of this team who discussed the ASLD guidelines pointed out and discussed the issue of using only transaminases and HBV DNA. As I already pointed out before, if you are stuck with this very simple but poor logic, then it becomes complicated, because transaminases can elevate, can be different levels in the single individual. So as you see in the discussion, there is sufficient evidence, sufficient but not complete, only based on transaminases, because transaminases can be an unspecific marker of liver disease. Of course, the condition is those who have a patent advanced disease should be treated, but it's also an issue to discuss about the evolution of chronic hepatitis to cirrhosis and hepatocellular carcinoma. If we start very late during a natural history, maybe the impact on prevention of hepatocellular carcinoma will not be so important. So the issue is maybe treating as early as possible. Treating immunotolerant. Here the agreement is that, and the recommendation in almost every guideline is really that selected group should be treated, and of course selection comes to the logic analysis of the single individual. Adults, more than 40 years of age, and so and so. And liver biopsy is back an important issue that we have a little bit forgotten, because in the past, in my time, we used to biopsy almost everybody. Now we biopsy almost nobody. Probably the best way is to biopsy more individuals when to have to make a medical decision. The issue of hepatocarcinogenesis has to be addressed more carefully, but the real concept is that since it is a longer pathogenesis for years, starting earlier and longer with therapy probably will make better results than treating later. And for this reason, I finish with the slides that we use in the Italian guidelines. We prefer to make a logic scheme than to make a series of written rules. And this scheme were quite successful, and we kept them for more than 15 years, and now we are a little bit changing, but not much in terms of the basic concept. The basic concept is that in the E negative, hepatitis B, where it's more difficult to make a decision, we have PEG interferon and nucleoside-nucleotide analog. The earlier is the evolution of the disease, we choose more interferon, then the choice goes to nuke more consistently later. Then you see that we have an overlap phase, and then there is a phase where we can decide according to the single cases, and this is based on the level of necroinflammation, other parameters that we will discuss during this day. Consider treatment, as you see, is below was the statement. Nowadays, probably we have to say anyone who has a chronic hepatitis should be treated, because the best prevention is to start as early as possible. Nowadays that we can be very consistently able to distinguish the inactive carrier from the very early chronic hepatitis B, not to treat is a big mistake. And so we'd say current therapy is an unfinished job. We have two drugs, but we can dwell better with them, combining, making more sophisticated approach to different categories of individuals, and starting suppression as early as possible to avoid the long-term complication of hepatocellular carcinoma, even in those who are cured by chronic hepatitis. Just to finish, I just want to jump to some economical issue that I saw Professor Tongsawat pointed out. We know that we can make a decision now. We start to have markers to identify responders to interferon quite early, particularly in genotype D. This is the condition in the Mediterranean area. Genotype D is a condition where the levels of antigen are much more helpful, because in the first phase, these are the different dynamics that we have seen in the different genotypes of hepatitis B. In genotype D, the real point is that during therapy, during the first weeks of treatment with interferon, there is an increase of levels of surface antigen. That's something that does not happen in the other genotype. This is very helpful, because those who have a decline are really those who are responding. So there is a better possibility in the time frame of the first few weeks to make a decision in this genotype. And using them in the Mediterranean area, we can have a very successful way to monitor those who respond after a few weeks, then start nukes later in those who don't respond. Just to make, and this was the famous pattern of the rule of the 12 weeks monitoring proposed by the group in the Netherlands, then approved by in secondary cohorts. What we make in a published economical effectiveness study to make what is currently done in Italy, for instance, and compare what would happen if we would start interferon in everybody, then decide later, after 12 weeks, whether to go on or not. This study on cost effectiveness has shown clearly that, of course, the efficacy is better if you start earlier. So it's economically convenient not to wait to start in everybody. But what happens today? In Italy, this is the spectrum of 3 years ago, 30% PEG interferon, 30% entecavir, tenofovir 26%. This is the scenario of the use of the drugs. Provided that instead of using that, everybody would start with interferon, then switch after 12 weeks. This is the spectrum of economical gain. If only 25 of the doctors would follow that, we will already spare 19 million euro per year. If about 80% would switch to this strategy that is possible, we would spare 55 million per year. So you may see the strategy of starting with interferon, at least in genotype D area, is a strategy that makes a lot of money sparing, providing the very well done management of the cases in real practice. Thank you very much.
Thank you very much for your comprehensive talk. We will have about maybe a few minutes for the discussion. I think there may be many questions from the floor. Any questions from the floor? Professor Tila, any question?
Because I really enjoy first your talk, because you come back to the interferon. I always say that, Dr. Tila here, interferon guy, and maybe less than 20% now using interferon in Southeast Asia, but you can see, you talk about E-negative disease, and you also say that in Italy, about 1/3 still use interferon at the first line therapy, and resulting co-effectiveness. And that's really go along with the nice recommendation. When they talk about lifelong co-effectiveness, they found that interferon is the most co-effectiveness. Now come back to the question, and how about in our country, the majority of patients still E positive. Which one should be the first line therapy for E positive in terms of co-effectiveness?
Actually, in our area, the number of cases E positive were almost less than 5%. Now we are facing a change a little bit because of the increase because of the immigration, and we have different genotypes. So according to what I was saying, it's becoming a personalized decision making. And so it depends on the genotype of the patient, and then you can make a decision according to genotype, according to the phase of hepatitis, for sure. But I think the important point is in terms of medical decision. Once we have a chronic hepatitis, independently if E positive or E negative, we have to think to induce, in the first case, seroconversion as early as possible. In the second case, to induce immunocontrol, then to stop treatment and have a maintenance of immunocontrol as early as possible, not a treatment lifelong, particularly when decision is made in the very early phase. Because when we are talking about chronic hepatitis without cirrhosis or with minimal degree of fibrosis, we are talking about decades of treatments if we use NUCs only. So the fact that we can identify whether you are a responder or not, either E positive or E negative, in the early beginning with interferon can actually open the issue also to a very effective treatment in terms of logic. And in the young people, particularly in chronic hepatitis B, the tolerance of interferon is much better than in advanced disease and in hepatitis C, because in the literature there have been published work. If you would run a meta-analysis on the side effects due to interferon in chronic hepatitis B clinical trial versus chronic hepatitis C clinical trial, there is a consistent difference in the tolerance. So this is something that could be done more consistently also in terms of evidence-based data.
Okay. Really brief, because I think, remember, you told me over 10 years ago that you're using a lot of anti-SB core. Now it's one study from China. They look at the anti-core quantification, the baseline, and dynamic anti-core over time of PEG interferon treatment in Hep E. They found that it have a really good predictor of response. What do you think about anti-core quantification?
Maurizio maybe will discuss more in detail this issue later on, so I will not go on that discussion deeply. The only thing in the Mediterranean area, we were looking and we dwell a lot on the quantitation of IgM anti-core about 30 years ago. Then, unfortunately, most of the company didn't develop a good assay with a good quantitative range for that. The quantitation of total anti-core is just making an exploitment of that issue, because you measure both IgM And so it's a marker of HPV-related disease. So nowadays, with the better assay, better quantification, better range of dynamics, makes that issue very, very important. So I think I agree. We have an additional tool to make that. But the issue is also money. So, since there is also standard interferon, was very effective. It was only a matter of compliance. So standard interferon is very cheap. So therapy can be very cheap. If we use that in country where there is not enough money to support, therapy for hepatitis B can be very consistently effective. Using a standard interferon maybe in the beginning and switching to NUC in those who don't respond. But of course, the genotype make a lot of difference. So we need the studies because in genotype D, as I said, the rule of 12 weeks works well, but it does not work as well in the other genotypes, and we need to check that.
Thank you.
Thanks. This is for Professor Satawat. I just want a little bit of a clarification of the roadmap concept in Thailand. You said you start off with lamivudine, and then if you develop resistance to lamivudine, you switch to tenofovir. I mean, or is it after a certain period of non-response you switch? It seemed like it would be a little odd to kind of push the drug till they actually develop resistance to switch. Would it be reasonable after a certain period of time when they don't respond to switch before they actually develop resistance to a drug?
Yes, until now we still use the roadmap concept developed by Emmett Kiff and also Tirat. We test the viral load at
6 months.
the 3 and 6 months, and if the viral load is not undetectable at month 6,
Yeah.
That's gonna switch.
All right. I just want a clarification. Thanks.
Any questions? So I would like to ask Professor Bonino. For compensated cirrhosis, patients who have low detectable viral load less than 2,000 IU per ml, for example, the recommendation between Western and Asian are quite different. Asian recommend to follow up closely until the viral load exceeded that level. But in Western recommend to treat any patient with any detectable viral load. What is your practice?
My opinion is that it's better to change or add oil to the engine before it breaks, still waiting the first symptoms. So it's out of doubt that we have to treat anybody as early as possible once chronic hepatitis B is present. So if you have already cirrhosis, the point is cirrhosis is already asymptomatic for many years. Maybe it would have been better to treat even earlier. So I think this issue of waiting viral load in a case, because you are not dying because of viral load, you are dying because of cancer due to cirrhosis for many years. And the hepatocarcinogenesis is working. To let it go is really a danger. So ethically, it's completely wrong not to treat somebody at that point as early as possible. So the intervention should be vaccine first. If you don't have the lucky part of being vaccinated, you have infected. If you have active disease, you have to be treated. Because active disease is the point, even very early. The earliest, the best. Because nowadays we have seen the data that if you cure chronic hepatitis, once you have already cirrhosis, the risk of cancer is not cancer. And there is a question whether it's working or not working. As long as you wait, the lower is the impact on the prevention of hepatocellular carcinoma. This is something that is coming step one. The other issue, very important, is genotype. Maybe in Asia, genotype C and B have a different impact on the natural history. But hepatocellular carcinoma is impacting in Asia strongly as in Western countries. So I think, of course, we need to study, but it seems very reasonable in a physiopathological concept that to treat as soon as possible is probably better.
Okay. Okay. We are running out of time, so we move to the next session. Thank you for your attention.